This series of videos is intended to help the OR personnel orchestrate an anterior approach hip replacement as described by Joel Matta. What that will entail is the utilization of the orthopedic table in the safest way possible for you and for your patient, as well as the use of the C-arm navigation for component placement to optimize the advantages afforded by the direct anterior approach. We'll also talk a little bit about safety checks for the orthopedic table itself, as well as just some of the tips and tricks, not only of patient positioning, but also the entire choreographed dance that the OR personnel are critically involved with as we take care of these patients. When we start setting up the orthopedic table in preparation for an anterior approach, one of the things that we make sure is ready to go is the elevation of the bracket. And the bracket is this device which gets hooked up to a post on this table. It's an automated way to help the surgeon expose the femur during the surgery. One of the big advantages of doing this operation on the orthopedic table in the first place. Now for that to happen, the automation occurs with this, which is a foot pedal. The surgeon has access to this during surgery. It needs to be plugged into the table ahead of time. There's a device just right here, and the reason we go through the effort of making sure you all know how to do this is that often halfway through the case, if that's not working, you're stuck in the water and nobody really knows what to do. So the first thing we do is make sure that the foot pedal is plugged in. The next step is going to be applying the spar or the leg holder to the table base itself. And this is a locking mechanism mounted to the table, which is going to come through here. We're going to explain and demonstrate exactly how it goes. However, before doing so, I think it's worth taking a moment to look at the locking mechanism itself. The post of the spar will go into this hole, and there's a locking device here that, when elevated or descended, allows the post to slide in and out, and then the definitive lock here, which is a spindle. The next thing we're going to demonstrate is the application of the spar to the table itself. It's a two-person job. It's fairly heavy. The person on this side of the spar is going to work to marry the post into the receiving end of the table. This takes an elevation of the locking mechanism, sliding it in. Now your partner will hold the spar up to be able to definitively tighten the spindle, and in doing so, lock the spar into the table base appropriately. The next part in the table setup is applying the post or the elevator to the table base, again for the automation of the femoral preparation. This is the right-sided post. We're working on the right side of the table. Almost always, this has been labeled. The way that you want to apply it is such that the post, from the portion of the table, the post itself is distal to the insertion. So if you have the wrong side, for example, if I had the left side, the post itself would be cranial. We want distal to the table, inserted about a hand's breadth away from the metal portion of the spar. Once it's been applied, we tighten and lock the piece onto the underside of the table. Once the lift has been attached to its receiving end on the table base, we now plug the cable into the box, which allows the table to automate through the foot pedal. That goes just like this. And once that's been accomplished, you'll then be able to elevate the lift to which the bracket and the hook are applied during the surgery. The last part of the table setup is applying the arm boards. Now, on this orthopedic table, the arm boards are able to swing out and swing in so that the patient can be transferred without having to actually attach anything to the table. So when we're ready to, this arm board will swing out. Now remember, the patient's pelvis will be about this distal on the table itself, so we want the arm board positioned in this general area. There are three areas here that will be used to attach the arm board. This spindle, which locks the arm itself into position, and then these two, which allow the board to be introduced into a hole here and applied, and then positioned for every patient distinctly. So now we're just going to talk about a safety checklist that we recommend before bringing the patient into the room and beginning to position the patient onto the orthopedic table. The first thing, just like any table, is to make sure that the table is locked. On this particular table, there are 4 mechanical locks, 1 for each wheel, and you simply have to, with your foot, lock them down. So once the table's locked, the next thing to do, at least in my OR, is make sure that the table is working, that it's plugged in, and that mechanically everything is going to be working during the operation itself. So where we're going to come to the head of the bed, there's a hand mechanical device here. The first thing I just do is push the return to level button. Now there are 7 buttons on this. The 7 buttons bring the table up and the table down, rolls the table, Trendelenburgs the table and does a reverse Trendelenburg, rolls the table to the left, and rolls the table to the right. So those are the 6 mechanical options that you have with this table. And there's a lot of dispersion, so you can really roll this thing. Often a surgeon will end surgery with the patient not in a level position. Patient will leave the operating room and the table will be clean like that. You as the next surgeon to use the table want the table leveled in all axes before you start. So just by pushing return to level, you're checking that number 1, there's power going to your table, and number 2, that it's completely flat in all positions. When it starts just going down to the floor, it means that there's no Trendelenburg, it means that there's no rotation, and it's now simply going down to its lowest position. Every once in a while, the table doesn't seem to be working. Of course, the first thing to do is check that it's plugged in. If it's not plugged in, there's a routine to go through to reset the table base. So the hand control is one way to work the table, but a second way is that on the base of the table itself, there's a keypad. Now the keypad and the hand control have the exact same 7 command buttons. The height up, the Trendelenburg, and the roll, as well as the return to level. If the hand control is not working, the first thing to do is see if the keypad works. So for example, if your hand control is not working, but your keypad is turning the table as you wish, it simply means that your hand control is not working or it's not attached to the table correctly, and that's an overcomable problem for sure. You can simply finish a case with the keypad as long as you have a willing CRNA or anesthesiologist. If, however, the keypad's not working and the hand control's not working, it indicates that you're not getting sufficient power to the table for some reason. What you want to do in this case is reset the table. Now, there are lots of ways to do that, but what I'd advise is recognizing that there's a red button here on the side of the control panel. The red button says reset. What you would do in this case is push the reset button, turn it to the side, the table can be turned on. Now, if the reset option and just unplugging and plugging back in the table doesn't work, there are 3 circuit breakers here to the left. Pushing each of them and then re-pushing them should restore power to the entire base of the table. The last thing that I want to show you on the control panel, since we're here, is that on the control panel, it also has this toggle switch that allows us to change the femoral lift power from the left to the right side. Similarly, there are 3 buttons here that indicate you have successfully plugged in the left, the right, and the foot pedal to the table base and that they're functioning. The next box to check on the safety check is the lifter. So a couple of things that you want to check. Number 1 is its position. So again, it should be positioned so that it's about a hand's breadth away from the metal portion of the spar. If it's too far north, it means you've got the wrong-sided lifter attached to the table. It should be about a hand's breadth away from the spar itself, and then it's tightened definitively with this knob to make sure it's stable. Finally, you want to make sure that there's power coming to the right side so that it will come up and down. That's where you check your foot pedal that it's coming up or down. If it's not, the first thing to check is that it's plugged into the table, and secondly, that the toggle on the control panel is appropriately indicating the right side. When I start surgery to transfer the patient onto the table, I put the lifter into its lowest position, so I go all the way down with the lifter pedal. The final point of the safety check involves the spar itself. And there are lots of ways in which the spar's attachment to the table can be inappropriate, and then the use of the spar itself can certainly at least be concerning to the OR personnel. So first, how do you know that the leg spar is attached appropriately to the table? It needs to be locked definitively. If you'll just notice, in this case, and this is very common after the table has been cleaned, there's some laxity here in the lock itself. So of course, you'll notice there's toggling here. So in order to lock it down, we need to take gravity away from the mechanism itself. So we'll ask our assistant to hold it up, take the gravity away, and now I can almost always tighten this substantially. Now you can see that it doesn't jiggle as it had been before. So that's the first thing to check every time. I'll point out that there is a locking mechanism on this particular orthopedic table. We saw it earlier. This is not going to fall onto the ground with the locking mechanism in place. However, you do want it locked very tightly. The second point of safety for the spars themselves is to make sure that they're positioned appropriately to transfer the patient onto the table. And what that means is that typically when the cleaning crew cleans the table, they've moved the spars into a position that's somewhat descended from a neutral position. You want the spars to be at a position of neutrality to accept the patient's feet when it's time to position the patient. So just a little bit of flexion, or at least straight and stable, not at all in an extended position for the transfer. There are 5 different knobs or buttons that you need to understand, or at least the person who's going to be involved with moving the spar during surgery need to understand well. The whole point of the leg spar is that through one mechanism or another, we can position the patient's leg anywhere in space to facilitate the surgery. And that's very powerful, but it also involves a certain level of risk if you don't know how to do so safely. I think the first thing to recognize is that there's some weight associated with the spar. Now, this spar is made out of carbon fiber, but that said, it still, especially with a large leg in it, can be somewhat heavy. This is a two-handed maneuver when it's completely unlocked and you're moving it when there's a human leg in it. The first knob to understand is the lock-unlock position. When this knob is turned to the left or to the outside of the table, it allows me to move the spar through the attachment on the table, and I can put it pretty much anywhere I want. During the surgery, this will be used to extend or flex the spar, and may be used to AD, adduct, or AB, abduct the leg. The way that this is locked and unlocked is through this mechanism here. It's not a tight, forceful locking. This is all that's required. What we see commonly is people, in their concern that it will unlock during surgery, try and force the knob far to the interior, and that's unnecessary. You simply want to unlock it such that there's freedom and lock it to the point just past midline, at which point it's completely locked. The second knob to understand is what is labeled gross traction. Unlocking to the left or locking to the right allows this box to slide on this rail. What that will do, if it's unlocked, with just your hand, you mechanically pull traction on the patient's leg or relieve traction on the patient's leg. You'll pull to a position as dictated by your surgeon and lock it, which will keep it from moving any further. So the terminology we tend to use for the gross traction is release the gross or unlock the gross, apply gross or pull the gross. So release the gross, now there's free motion of the gross traction. Lock the gross, simply locking it in place, it won't move any further. Apply gross means that your surgeon would like you to pull traction and lock the gross. That's the gross traction. Now, the third knob to understand is that once the gross traction has been applied, the spindle at the end of the spar will now allow additional quote-unquote fine traction. So we achieve a gross amount of traction and lock our gross there. Now, with this spindle at the end of the spar, we're able to apply additional traction through this mechanism. In order for that to work, when you set up your table, you need to have a little bit of silver visible here. If there's no silver visible here, you'll not get any further gross traction. So the amount of, fine traction. The amount of fine traction that you can apply is this much. By applying this in a clockwise manner, you'll obtain that much more fine traction. The fourth knob to know about is the rotation knob. Now, on the rotation knob, there is a degree, there is an indicator if it's set at the beginning of surgery to 0, telling you that you have internally rotated 40 degrees or externally rotated by this amount. If you want to use that indicator, make sure it's set ahead of time. By releasing the rotation, utilizing the steering wheel at the end of the spar, you can externally or internally rotate. It has control over the area of the spar that the boot has been attached to. Unlocking it is turning it to the left, locking it is turning it to the right. And then finally, there's an additional way to allow a rotational component to this, and that is this spindle right here. And this is where the boot will attach to the table. By locking this with a clockwise motion, it becomes definitive. Unlocking it allows freedom here. Typically, what this allows you as a surgeon is some change in the flexion of the foot or the boot once it's in the table. We'll show you that when we talk about patient positioning a little bit more, but that is the final knob to understand in overall when using the spar. The final point worth mentioning as far as a safety check with respect to utilizing the spar involves extension. Now, the position for femoral preparation is the leg in an extended position with a small amount of adduction to better expose the proximal femur. The femoral nerve is fairly susceptible to stretch, and if there is traction applied to the leg in the extended position, the femoral nerve can be put under an inappropriate amount of stress and lead to a palsy. Therefore, when you're preparing to expose the femur with extension and adduction, the first thing that we do is release the gross. So with the gross released, now when we come into extension, the patient's leg will become more proximal such that there's no traction on the leg, pulling it, and therefore relaxing the femoral nerve, or at least working against any undue stress across the femoral nerve. So the command that we typically utilize, or the language we encourage, is when we're preparing the femur, or preparing to prepare the femur, we release the gross and then extend the hip and then adduct the hip. You'll notice that there's a place on the table that says red zone. And what is that there for? In the situation that you have a very short patient whose leg is going to stay here just by virtue of the length of their leg, applying the gross, going into extension will not be affected by the lack of gross traction. You'll still be pulling on the leg. So if you find yourself in this position, what's recommended is that you obtain what's called an extender. The extender will go into the boot control and lock in. Your boot then goes in to the extender. This term extender indicates that we've now extended the length of the spar such that in these short legs, we can position the box in a position such that when we do go into extension and release the gross, there will be some pliability and flexibility for the femoral nerve itself. We're now going to demonstrate how to position a patient safely on the orthopedic table in preparation to do a left-sided anterior approach hip replacement. The patient comes into the operating room depending on how your particular OR is set up. In this case, you'll see that the sterile tables and all the instrumentation is on the far side. We'll be preparing to bring the C-arm in from the non-operative side, again with the left side being the surgical side in this particular case. We've done all of our safety checks for the table ahead of time. We've positioned the left-sided or the operative side arm board in preparation of receiving her left arm. Now the right-sided arm board has been flush with the table and is not on so that we can transfer the patient successfully in that direction. We've done all of our safety checks on the spars. We've got the boots in the room and whatever padding we're going to use for the boots. Now the patient comes in and all anesthesia is delivered while the patient is on the hospital gurney or the bed, not on the table itself. And I know that that's a bit of a deviation from many orthopedic procedures or any surgical procedures. The reason is that once we've prepared the feet in the boots, they can be somewhat painful or at least tight, so we'd like the patient anesthetized ahead of time. Additionally, we want the patient to be asleep before positioning the patient's extremities into the 4 different positions on the table itself. So in this case, we're going to just demonstrate how one might go forward with the spinal anesthetic. In this case, on the patient's gurney, go ahead and sit. We're going to have her sit up. We've set a stool for her so she can assume the spinal position with a little bit of flexion in her back with your head down. Your nurse will typically assisting the patient, and the anesthesiologist can then approach the patient from the back side, either by moving the table a little bit away from the the gurney away from the orthopedic table, or moving the orthopedic table a little bit towards the sterile setup. Once the spinal's been done, patient can lay back. Now, if you're using a general anesthesia, again, we really recommend that the patient is anesthetized on the gurney before being moved onto the orthopedic table, because we're going to apply the boots to the patient's feet and then use the boots for the transfer onto the table. If you use a Foley, this is the time to place the Foley. The SCDs can be applied on the operative and non-operative legs according to surgeon preference. At this point, once the patient has either been anesthetized or the spinal anesthetic has come into effect, it's time to place the patient's boots. Now, as explained previously, the boots for this orthopedic table come in 3 different sizes. These are small boots. They then come in a large and an extra large. You can spend all day looking for the medium. Doesn't exist. We've got small, large, and extra large. There are various ways in which the boots can be padded. In this case, we're going to be using a padding that can be ordered in a kit with the table. This pad is disposable. We're going to be checking always that the right boot goes on the right foot. It seems like a silly thing to even think about, but it's very easy just looking at the boots to apply it to the wrong side. I'm going to ask for somebody to help me here. And opening up the shell of the boot, I'm going to tighten the padding around the patient's foot and ankle and just seat the heel into the very base of the boot. Thank you. The key here is that we want the patient's foot all the way into the boot, particularly on the operative side, such that when we apply traction, the foot doesn't slip out of the boot. Now, in this case, we've got I can put my finger in through this hole in the base of the boot and feel that her heel is not down. Some tricks to get the heel down include bringing the knee into some flexion to release the Achilles a bit, and then pushing the heel into plantar flexion. Now my heel is down completely. In this position, we can start to ratchet down, always starting at the middle crease attachment, and then the more proximal. Much like a ski boot or a rollerblading boot, tighten until the heel is firmly seated. Again, double checking with the finger test to ensure that the heel is all the way down. When I bring her leg back into full extension again, I want to make sure that the heel has stayed down. In this case, it has. If it hadn't, I would reposition the leg back up and ratchet this middle ratchet down further. In this case, we've used a pre-created foam that comes with, particularly made for these boots and the shells. There are lots of other ways to do this. Some surgeons use the foam padding that comes with the boots. Others have used a cast padding. The key is to pad the bony prominences within the feet such that there won't be any kind of compressive palsy secondary to the tight boots on those prominences. But secondly, ensuring that the shell won't slip over the boot or over the padding or whatever you've chosen. And this becomes particularly important in cases that are complex or difficult as far as how much traction you're going to need or be able to apply during surgery. Some surgeons will use a co-band either over the boot itself, particularly in more difficult cases that are perceived to be more difficult during the surgery. Suffice it to say, there are many different ways in which to secure the patient's foot into the boot. You want to make sure that the boot is not going to slip off of the patient's foot during surgery, whatever makes sense to you. But finally, I'd say that there is a risk of causing too much compression, particularly in longer cases. So if the boot is over-tightened, and I truthfully recommend that everybody that's ever going to put patients' feet into boots, try this on themselves and just feel where it gets tight and where it gets uncomfortable on your own foot. The patient's toes can get tingly, and there can be some longer lasting compression palsies if there's an over tightening of the boots or if the boots are left in a compressive way for too long of a prolonged period of time. Those are all things to think about when applying the boots themselves. Now we're going to talk about the actual transfer. So getting this now anesthetized patient with the boots applied onto the orthopedic table. In this case, making sure that their legs are secured into their spars and then the arms securely fastened on the arm boards to perform the surgery. This is going to be what we'd recommend as a 4-person transfer. We have 4 people, each of whom have a very specific job in making this transfer not only efficient but incredibly safe for your patient. The person that's going to be in charge of the patient's feet, I'll call the boot master. The boot master's only job is going to be transferring the boots into the spars and securing them into the spars definitively. That person, and I'll ask that person to come help me now, recommend that that person stand here between the spars, make sure that the receptacle for the boots are loose, that the gross traction is off, and that you can mechanically reach the feet and then be ready to hold them here. That's going to be the boot master's job. Once we have the patient over towards the center of the table, one boot at a time will be secured into the spars themselves by this person with a little bit of assistance from one of the other 2 people. That's the boot master's job. The second job is going to be the receiver. The receiver will stand right here and be responsible for taking the patient's sheet, rolling board, or transfer board, carrying the patient's torso to this portion of the table. Once the patient is in this position without moving, the receiver's body prevents the patient from coming too far over the table and towards the sterile back table. Once this receiver has the patient in this position, they will take the perineal post and position it between the patient's legs, thus securing the patient's pelvis to the table. This is going to happen in conjunction with the boot master securing the feet into the spars. That's the receiver's job, and they don't leave this section of the table until the perineal post has been applied. The anesthesiologist is an active part of this transfer. The anesthesiologist, obviously in charge of the patient's head, but at this point, when we're ready for the transfer, the anesthesiologist will be calling out the orders. We will do everything on the anesthesiologist's timeline. but the pillow that the patient's head is resting on will be passed to fill the gap between the orthopedic table and the gurney, over which the patient will be transferred. This becomes relevant when one looks at the contour of the orthopedic table, which is cut out here. No matter how close we get the patient's gurney to the base of the bed, there's always a space here. So the anesthesiologist, before counting off, will hand off a pillow and let it sit in this position, then be in control of the head on the transfer to this area of the table. The final person in the transfer is what we call the quarterback, who is going to push the patient to the receiver. And that person's job and responsibility is not only transferring the patient by pushing, then removing the sliding transfer board and moving the gurney out of the way to finalize and position the right arm board for the final part of the transfer. So we've just moved our patient onto the orthopedic table. I, as the quarterback, have been responsible for moving the gurney out of the way, and I can now position this arm board at least into a fairly gross position such that we can think about uncrossing her arms. This is my first job as the quarterback. But before we uncross the arms, we need to make sure that the receiver is doing the same thing on the other side. I then, as the quarterback, turn and take this leg from the bootmaster. I will then work on this leg while he works on that leg, applying them into the spars, into a gross position, which will then be finessed at the end of the patient positioning. Now, once we've got the feet in the spars, and I'll just point out that these jobs all occur simultaneously, but I'm just going to point them out one by one. The receiver, who is standing here again, making sure that the patient's body can't come too far off the table in the far direction, is going to first start by putting the perineal post into its position. After doing so, and once the 2 feet are secured in the spars, it's very difficult for the patient to fall off of the table. So that's critically important. The post comes in, and then once both feet are in the spars, we'll position the patient's pelvis onto the post just a little bit, typically onto the post a little bit distally. At this point, the receiver and the quarterbacks are in a position to unhinge the arms and allow them to lay on the arm boards. This is when typically people go off to their other jobs. The receiver may be the circulator, the bootmaster, maybe a positioning assist from a different room. At this point, it can be the primary assist or a single person doing the rest of the fine positioning. As far as the patient's arms go, these arm boards are able to be positioned in 3 different levels of control. I'll come over to this side to show, but things that we think about are making sure that the arm is positioned in a way that there's a little bit of flexion in both the elbow and the wrist, and then the anesthesiologist or the CRNA typically will secure the patient's upper extremity into a position. On the operative side, it's important to position the arm in such a way that it doesn't block the post or the lift during surgery. So ensuring that there's enough abduction in the arm that the surgeon can both work in this position but also have access to the post intraoperatively. And make sure that there's not undue stress on any of the plexes with a little bit of flexion and yet padding of the bony prominences is important. Once the patient's upper body and upper extremities are well positioned, we can fine-tune the lower extremities. Starting on the operative side, you'll notice that there is no leg support, at least in my operating room. I don't use a leg support under the operative side. The reason for that is when I start to manipulate the leg into extension, often that support will hit the floor. So I don't use an operative support or a leg support on the operative side. I do, however, at this point, adjust the spar such that it's in a neutral position with the table, a little bit of flexion, lock down, And then I'll apply just a little bit of internal rotation to the patient's operative extremity. This will be important for exposing the tensor fasciae lata muscle belly to aid the exposure of the Hooter exposure, the Hooter interval. On the non-operative leg, I'll start by matching the flexion as well as the abduction into something neutral, ensuring that the patient's pelvis is fairly stable on the table, level on the table, and just as equally on the left side as it is on the right side. Again, just to match for intraoperative fluoroscopic navigation, a little bit of internal rotation on the contralateral extremity. And then the leg support is positioned in a way that it will allow a little bit of flexion on the patient's knee. I'm pretty careful to position this in a way that it doesn't apply any pressure in the popliteal fossa, but just a little bit of flexion into the patient's knee to avoid any hyperextension during surgery that's unnecessary. The final thing that I do before preparing to prep and drape the patient is apply just a little bit of traction to both the operative and, more importantly, to the non-operative side. This stabilizes the pelvis in a way that as you now proceed, doing any kind of manipulation of the operative side won't necessarily affect the patient's pelvic positioning on the table. At this point, the patient's body is safely positioned on the orthopedic table. The upper extremities are both secured through some kind of anesthesia taping or towels or adhesives to the arm boards. The midsection, the torso and the pelvis are very secured by basis of having the perineal post in position, and the legs associated with the leg spars ensure that the patient, all four points of the patient's extremities are applied to the table. It's very difficult for the patient to fall from the table at this point. That said, on occasion, depending on your OR personnel's policies, it may be important to apply a seat belt. The seat belt is applied here, and the critical thing about applying a seat belt or any kind of strap is that they're positioned inside the spars and not around the spars. The reason for this is that the spars are going to move during the surgery, and if there's a lap belt or any kind of tightly applied circumferential binder that's on the outside of the spars, with manipulation of the spars, it can cause undue pressure to either the thorax or the abdomen during surgery. So if you do feel inclined to use any kind of seat belt or adhesive belting, make sure that it's within the confines of the spars and not around them. At this point, I think we're ready to prep and drape the patient. Once the patient has been safely positioned on the orthopedic table, and the surgeon and the assistants are out washing their hands, we can start moving all of the other pieces into place for the surgery itself. The back table will be set up depending on how each surgeon prefers their OR to be set up, either a stacked table or two combined tables. Many surgeons will use a secondary Mayo stand with their immediate exposure equipment on it. Suffice it to say, this is all obviously on the right-hand side, on the operative side of the room. Now we're going to prepare to bring C-arm in. Now the C-arm shots start at variable times in the operation depending on each surgeon's preferences. In my case, when I get ready to make the femoral neck cut will be the first time that I take an image. Some surgeons will take an image before surgery starts, and this is the time to do it right now. Suffice it to say, we're going to go ahead and bring the image intensifier. When I'm standing here as a surgeon during surgery, I need to be able to see the image intensifier right here to my left. So we'll go ahead and bring the monitor here, and maybe a little bit that way, a little bit further out, because the circulating nurse or whoever's running the spars is going to need a little bit more room to drape the patient. So something like this is going to be appropriate. Now, in doing the surgery, typically the one assistant that a surgeon has is standing across from them. So at this point, when we're ready to start using C-arm, your assistant needs to step to the side and kick any stool that they might be standing on to the side, at which point I can ask the C-arm to come in, the radiology technician to bring the C-arm in. And I'm going to stop at this point to say that this is going to give me an AP pelvis. I need to be able to see my monitor, which is here to the side, in my case, here to my left, with the C-arm coming in and out directly towards me. I'll ask you to pull back with the C-arm for a second and just stop right there, demonstrate that we really can't have set up our cell saver or our suction or any kind of garbage cans or anything in this area, or it'll block the C-arm's ability to efficiently come in and out for the radiographic portion of the procedure. And in the anterior approach hip replacement, as described by Joel Matta, using fluoroscopic navigation is a big and very important part of the procedure's effectiveness. So being able to do this efficiently is critical. Those of us who've been doing the anterior approach for a while have learned that the efficiency of language is a critical part of the overall flow of the operating room. And I'll start by describing that as it pertains to the radiology technician. Our language and the radiology technician knowing what I mean when I say these things is critical to the execution of each movement appropriately. So I'll start by just saying, come on in with C-arm, in and out towards me. Now, how I say this is I start with an AP pelvis. This is typically my first x-ray. And I will ask him to telescope the C-arm in and out, and the word that I use is in and out towards me, in and out towards you. Everybody can come up with a language that works for you in your operating room, but in my operating room, and again, I've learned everything that I know about this procedure from Joel Matta. What I heard him say for a year is in and out towards me, in and out towards you. Now, if I need the C-arm to move cranially or caudally, I'll say side to side, and there are two ways to do this. One is the C-arm moving the base, and one is the C-arm moving its flexion point. I almost always and exclusively ask the radiology technician to move the base. I ask him to go side to side north or side to side south. So side to side north, coming cranially on the patient with the entire base, versus side to side south, back to where we started. Now, for a finer adjustment, I'll ask him to release what we call the wig-wag. So release the wig-wag, and now I as a surgeon, and of course this has been sterilized with the C-arm cover, I have the ability to wag and adjust just in fine motion the north-south or the cranial caudal direction of the C-arm. Let's get it locked back into a neutral position. The next terminology I use indicates rolling the C-arm over, and I use the term rainbow. So if you'll release your rainbow, I can now adjust the C-arm to give me more of an obturator oblique or more of an iliac oblique, simply saying, just taking small images to try to get the most appropriate image for my particular patient. That's for me, release the rainbow, and I as a surgeon then actually control the rollover. Go ahead and lock it there. And then the final thing is adjusting what I use, what I call the cant. Many surgeons will use the term tilt, but for me, can I get a little cephalag cant? So we're gonna cant the machine to give me more of an inlet x-ray versus a cephalag cant, the opposite direction. So these are my consistent terms that I utilize for these things. Go ahead and let's zero back to a neutral position and bring your C-arm all the way out. So coming all the way out, allowing my assistant to step back in, and I would just like to take a minute and give you an example of what I might do at a time where I am starting to position for cup placement. So come on in with C-arm. And I'm going to focus on trying to get a good AP pelvis and match an AP pelvis that I've taken ahead of time. I know that the patient's perineal post is just caudal to the symphysis pubis, which is resting on it. So where this is, where the C-arm is currently located is probably just a little caudal to an AP pelvis. So I'm gonna say, can you side to side north for me? And we'll position the entire C-arm just with its base a little bit north. And I'll take an x-ray, which we're not gonna do today, given our live patient. Now notice that I need a little bit of extra refinement, but I don't wanna move the whole base. Can you release your wig wag? I'll position it just right. Go ahead and lock it there. Now I'll notice that it's too close to me, so I'll say in and out towards you just a little bit. Perfect. Now I'll notice that the patient's pelvic tilt is not matched to the preoperative films. Can you give me a little bit of cephalad cant, about 10 degrees? I'll take an x-ray, say, okay, that's a little bit too much. How about take 5 degrees out of that cant? That looks good. Release your rainbow. Image there, and finally, when I have it perfect, we'll lock it up, and that will be my position for reaming, and that I'll subsequently do my cup based on. Now, if I want to center on the patient's left hip, in and out towards me, I may have to make some fine adjustments. I'll go to a magnified position, go mag 1. These are the terminology agreements that I've had with my personal OR staff. This is what we use. I just highly recommend that everybody come up with a set of terms that they're going to use with their C-arm technologists in partnership over this procedure. The other set of language that's really important to have down before you start surgery is that which you're going to use with your unscrubbed assistant, in this case the circulator. Often operating rooms will supply an additional assistant for this particular role, but suffice it to say, what you say to the person, or the language you use with the person that's controlling the leg, is probably the most important part of the whole choreography of the surgery. When we start talking about just the simple commands that I use, start with applying traction or releasing traction on the leg. So we're going to use the patient's right side as a demonstration here. I'll ask Corey to please, can you apply the gross traction? And this gives a manual application of traction. Now, if I need a little bit more, I'll say, can you give me a turn of traction? This indicates I want 1 turn of fine traction applied through the mechanical device of the table. I ask the assistant to tell me how much traction is applied. So right now I know, because I've just said it, that there's 1 turn. Can you give me another turn? There are 2 turns on. Can you take a turn off? So release the gross. In my terminology, I typically say gross traction, and then if I just say a turn of traction, that indicates the fine traction. So can you pull the gross? That indicates pull the gross and lock it. And then give me another turn of traction. 1 turn on. That's the traction. Now, would you AB duct the leg? I typically do say AB because abduction and adduction are so similar to the human ear. I say AB duct the leg. Would you AD duct the leg? Now you'll notice we can only AD duct the leg so far until it gets into trouble with the other spar. Sometimes that requires, can we AB duct the contralateral leg to give me some more room? So now AD duct a little further, please. Now we've got more adduction, adduction across the leg. Return to neutral. Go ahead and abduct a little bit. Great, perfect. Can you return the other spar to its position? The next thing is rotation. Often what I'll do is ask, can you release the rotation? I'll put my hand on the patient's foot over the drapes and adjust the rotation appropriately without asking the unscrubbed assistant or the circulating nurse to do it for me. That's the vast majority of the time that in the way that I apply rotation to the table. So I'll just ask, lock the rotation. Many surgeons will ask the unscrubbed assistant or the circulating nurse to externally rotate 15 degrees. Now, if this is the way you're going to run your operating room, it's very important that you've checked that your degree rotation indicator has been set before surgery to 0. So return to 0, please. That's another way of applying rotation. Again, for me, almost always, I'll just put my hand on the foot and ask, can you release the rotation on the patient's right leg? I'll say, lock the rotation in this point of external rotation. As I'm working intraoperatively, I know that that's what I want. Go ahead and release the rotation, and I'll reapply it back to neutral. Go ahead and lock it there. Now, and when it comes time to approach the femur, anytime we're adjusting the sagittal plane extension or flexion of the hip, we need to make sure that we're remembering we need to release the gross. Why? We don't want to extend the hip with the gross traction on for fear that it will put undue tension across the femoral nerve. So as I get ready to prepare the right hip in extension, I'll say, release the gross. Go ahead and extend the hip. You'll notice that when Corey did that, he held the spar because it's heavy. Once we unlock the spar, the weight of the spar will take it straight to the ground. So he grabs it with one hand, unlocks it, and then carefully lowers it to the ground after the gross traction has been released. Once the spar is on the ground, I'll ask him, adduct slightly, adduction slightly, and every now and then I'll say, will you release the rotation? And I'll then rotate the leg. Go ahead and lock it there. The typical position for femoral exposure is an extension with the gross off, a small amount of adduction, release the rotation, and then with the leg rotated about 90 degrees. Imagine that I'm not getting quite as much exposure of the femur as I need. At this point, I might say, you know what? Let's start over. Go ahead and bring the hip back up, flex the hip, bring it back up to neutral, release the rotation, lock it there. Give me a turn of traction. Pull the gross, lock the gross, give me a turn of traction. Let's see if we can't release that hip capsule just a little bit more, get the patient a little bit more relaxed, and try it again. Release the gross. Gross is off. Release the rotation. I'm going to rotate the leg out as much as I can get it manually without doing too much through the table. Go ahead and extend the hip. So the gross is off, the hip is fully extended. I've got it somewhat externally rotated. Adduct ever so slightly. Great, now release the rotation. I got a little bit more rotation, lock it there. This is a lot better. Go ahead and lock the rotation. This might be all I need now to get the femur exposed appropriately for the femoral exposure. This might be a time to point out a little trick, some of the tricks to getting the femur better exposed. Once we're down here, if I still can't get where I'm going with the femur, one of the things I might do is ask the anesthesiologist to give me some Trendelenburg on the table. Right now, the amount of extension that the leg is in is dictated by the patient's height and the height of the table with respect to the floor, because the spar is on the floor. I can increase the amount of extension on her hip simply by bringing the table up a little bit. Now, that doesn't do that much as far as the pelvis is concerned. So especially in patients that have a wide pelvis or are a little bit heavy, which is clearly not our case today, but imagine if it was. If we now Trendelenburg the table, it will get her anterior superior iliac crest a little bit out of the way and help us further expose the femur. Now if it's time to go ahead and reduce the hip, the first thing I'm going to do is ask the anesthesiologist, return to level. You'll notice that that in and of itself has caused some flexion in the hip. I'll ask that we release the rotation on the leg. Go ahead and flex the hip up. I've got my hand. I'm ready to reduce the hip. Go ahead and pull the gross. I rotate in, release the gross. We've reduced the hip.